The nutrition care process is a standardized structure and framework used to provide nutrition care. The 4 steps are assess, diagnose, intervene, monitor, and evaluate. Each step requires critical thinking skills. Critical thinking integrates facts, informed opinions, active listening, and observations. It is a reasoning process where ideas are produced and evaluated. It includes the ability to conceptualize, think rationally, think creatively, be inquiring, and think autonomously. Nutritional screening is the use of preliminary assessment techniques to identify those who are malnourished or at risk for malnutrition. All members of the healthcare team can participate in screening. It should be quick, easy to administer, and cost-effective. Screenings and referrals bring people into the nutrition care process. A screening tool may provide some evidence of an emerging nutrition problem. If none exists, document that discharge from nutrition care is appropriate. The Joint Commission requires that a nutrition risk be identified in hospitalized patients within 24 hours of admission, but does not mandate a method to accomplish screening. Rescreening should occur at regular intervals during hospitalization. There may be a link between length of stay and worsening nutritional status. Examples of nutrition screening tools are listed. Note the acronyms and the features of all. The subjective global assessment includes information from the patient on dietary intake history, weight changes, GI symptoms, and primary diagnosis. The mini nutritional assessment, the nutrition screening initiative, and the Geriatric Nutritional Risk Index focus on older adults. The MST, Malnutrition Screening Tool, looks at recent weight loss and recent poor dietary intake in the acute hospitalized adult population. The NRS, Nutrition Risk Screening, includes percent weight loss, body mass index, and dietary intake in medical, surgical, hospitalized patients. The MUST, Malnutrition Universal Screening Tool, includes BMI, unintentional weight loss, and the effect of acute disease on intake for more than 5 days. Nutrition assessment is the first step of the nutrition care process. Its purpose is to obtain adequate information in order to identify nutrition-related problems. It is initiated by referral and/or screening of individuals or groups for nutritional risk factors. The critical thinking skills needed include observing verbal and nonverbal cues that can guide and prompt effective interviewing methods, determining appropriate data to collect, selecting tools and procedures to be applied in valid, reliable ways, and distinguishing relevant from irrelevant and important from unimportant data. 3 components of the nutrition assessment are review, cluster, and identify. Review the data collected for factors that affect nutritional and health status. Assessment data is clustered for comparison with characteristics of a suspected diagnosis. Data is organized into categories: food, nutrition-related history, anthropometrics, lab medical tests, nutrition-focused physical findings, and client history. These indicators are compared to identified standards and criteria for interpretation and decision-making. Indicators are clearly defined markers that can be observed and measured. Indicators may also be used to monitor and evaluate progress towards nutrition outcomes. A nutrition indicator is what will be measured. Nutrition care criteria are what indicators are compared against. Quality documentation should include date and time, pertinent data collected and compared with standards, and the reason for discharge, discontinuation if appropriate. Assessing nutritional status includes gathering information on the patient's dietary habits. When conducting a diet history, try not to ask leading questions, those that lead the client to the answer you are seeking, showing your bias. The food record is kept by the patient. The 24-hour recall produces the best information when the dietitian is involved, clarifying the exact types and amounts of food consumed. Thus, it is best conducted in the clinical setting with your help. The Food Frequency Questionnaire is a quick way of obtaining intake information from large groups, such as in community nutrition projects, and can be done without your help. The medical or health history includes family history of disease, present and past health issues, surgeries, and psychosocial data. This provides insight into nutrition-related problems. Physical findings must also be included in the assessment. Anthropometrics measure body structure and include height and weight. Note the formula used to calculate desirable body weight and percent weight change. The weight change formula stresses the significance of the change in weight and is used to assess potential nutrition risk. The tricep skin fold measures body fat, estimating calorie reserves. Note the arm muscle area is a good indication of skeletal muscle or somatic protein. Measuring the AMA is important in growing children. It is useful in identifying possible protein energy malnutrition. The body mass index compares weight to height. Note the healthy BMI for adults. Waist circumference is an independent risk factor for disease when out of proportion to total body fat. Note the waist-to-hip ratios indicative of increased risk for obesity-related diseases like diabetes or hypertension. Bioelectrical impedance analysis is used at the bedside to evaluate fat-free mass and total body water. The patient must be well hydrated, restricting caffeine, alcohol, and diuretics for the prior 24 hours. The BOD pod measures body composition. It determines body density by measuring the amount of air displaced. Note, a nutrition-focused physical examination includes the following. Inspection is gathering information through observations. Palpation is gathering data via touch, as in assessing fluid retention. Auscultation is listening to the sounds of the heart, bowel, and lungs. Serum albumin is a visceral protein found in the blood and organs. Its major purpose is to maintain colloidal osmotic pressure. When levels of albumin decrease, water in the plasma moves to interstitial spaces, causing edema. A serum albumin above the normal range is usually due to dehydration. Because of its long half-life, it does not reflect current protein intake. Serum transferrin is also a visceral protein. It transports iron to the bone marrow for production of hemoglobin. The iron storage pool controls the plasma transferrin level. When iron stores are depleted, transferrin synthesis increases. This is mainly used in diagnosing anemia. Transthyretin is a visceral protein that turns around in 2 to 3 days, so picks up changes in protein status quickly. It has limited usefulness in screening or assessment. Retinol-binding protein circulates with prealbumin. It binds and transports retinol. Hematocrit and hemoglobin together evaluate iron status. Serum ferritin indicates the size of the body's iron storage pool. Creatinine is released from muscle cells and excreted by the kidney with little reabsorption. Serum creatinine measures somatic protein, and together with the BUN assesses kidney function. The creatinine height index is a ratio of the creatinine excreted compared to height. The BUN is related to protein status and renal function. A normal BUN to creatinine ratio is 10 to 15 to 1. Urinary creatinine clearance measures the glomerular filtration rate. The TLC measures immunocompetency. C-reactive protein is a marker of acute inflammatory stress. As it declines, it is used to indicate when nutritional therapy would be most beneficial. Free erythrocyte protoporphyrin detects lead poisoning. Lead depletes iron, leading to anemia. The prothrombin time evaluates blood clotting. Anticoagulants prolong the prothrombin time. A change in vitamin K intake will alter the clotting rate. Analysis of human hair is not useful in nutrition assessment. It may be used to measure the intake of toxic metals. Energy requirements based on activity levels are listed. Note the activity factors. Some of the effects that drugs have on nutrient absorption and use are listed. Note the following. Megestrol acetate is an appetite stimulant. Oral contraceptives may decrease folate levels. Loop diuretics deplete potassium, magnesium, calcium, sodium, and chloride. The thiazide drugs decrease potassium and magnesium, but enhance the renal absorption of calcium. Methotrexate, a chemotherapeutic agent, decreases folate. Lithium increases appetite. Lithium and sodium are reabsorbed at the same sites in the kidney. Low sodium intake leads to the retention of lithium. Patients should maintain a consistent sodium and caffeine intake to stabilize the drug. 2-gram sodium diets may be too low. Anticoagulants antagonize vitamin K. Propofol is administered in oil, providing 1 calorie per cc, so consider the fat content. The immunosuppressant cyclosporine leads to hyperlipidemia, hyperglycemia, hyperkalemia, and hypertension. Isoniazid, which treats tuberculosis, depletes pyridoxine, leading to peripheral neuropathy. Take the drug away from food. It interferes with vitamin D, so calcium supplements are needed. Elavil may lead to weight gain. Vitamin B6 and protein decrease the effectiveness of levodopa. Take the drug in the morning with limited protein. Consume most protein with the evening meal. Tyramine can cause hypertension if consumed with MAO inhibitors. Foods to avoid are the aged or fermented. Advise the patient to buy, cook, and eat fresh foods. Socioeconomic factors to consider include those that influence food choices, such as income, price of food, time available to shop and prepare food, and proximity to food sources. What are their sources of nutrition and food information? What media do they watch or use? A general wellness assessment is a process that involves being aware of better health and actively working towards that goal. As you assess your client's nutritional status and needs, consider his readiness or willingness to make dietary changes. When assessing the needs of the community, obtain an overview of the nutritional status of the community as a whole. This helps to determine whether the community's nutritional resources are adequate, what groups are potentially at high nutritional risk, and how well the community's nutritional and related health needs are being met by existing programs. Note, the HRA, Health Risk Appraisal, is a survey that categorizes a population's general health status. Sources of assessment information include demographics, which looks at the community's population by age and ethnic groups. Other considerations are morbidity and mortality rates. Morbidity refers to disease, mortality to death. Note, the infant mortality rate expresses the number of deaths per 1,000 live births. Note the difference between incidence and prevalence. Incidence refers to the number of new cases of a disease that develop within a time period. This is a measure of the risk of developing the disease. Prevalence is the number of existing cases of a disease in a community. Also assess local health resources to identify the services offered and evaluate them. What are the cultural features of the community? What school nutrition and social welfare programs are available? What is the educational attainment and the native language of the community? Food security is having access by all people at all times to sufficient food. The Community Food Security Initiative is the development of sustainable, community-based strategies to ensure that all have access to culturally acceptable, nutritionally adequate food at all times. These strategies focus on local food systems like farmers markets, food recovery programs, prepared and perishable food programs. Food insecurity is prevalent among emergency food recipients. It affects all ages, ethnicities, and locations. It impacts the working poor. It extends to government food assistance recipients and those with poor health status. Note the difference between the nutritional survey and the surveillance. A survey examines a group at a particular point in time and is a cross-sectional study. It provides information on the prevalence of a condition at a specific time. Nutritional surveillance is the continuous collection of data to evaluate nutrition status. This data is used to identify nutrition problems, set a baseline, and is used in setting priorities. It detects changes in trends over time. Note, the system is based on height, weight, hematocrit, hemoglobin, and cholesterol levels. Surveillance should be an ongoing system linked to an active health program, like WIC and the CDC. Data used should be produced by these health programs. This data identifies needs and the kind of intervention that is needed. The Nutrition Screening Initiative focuses on the elderly and tries to identify their nutritional problems early. The NSI uses the Determine checklist to highlight the warning signs of poor nutritional status. The Level 1 screen identifies those who should be referred for a more comprehensive assessment. The Level 2 screen is used when the others identify more potentially serious medical or nutritional problems, so RDNs are most involved with Level 2. The National Nutrition Monitoring and Related Research Program includes all data collection and analysis activities of the federal government related to measuring health and nutritional status, food consumption, and attitudes about diet and health. The Pediatric Nutrition Surveillance System follows low-income, high-risk children. The Pregnancy Nutrition Surveillance System follows low-income, high-risk pregnant women. It counts the number of women who breastfeed. A goal is to identify and reduce pregnancy-related health risks. HANES is a repeated survey designed to determine the nutritional status of a sample of the U.S. population. It is based on clinical exams, biochemical tests, anthropometric measurements, 24-hour recalls, and food frequency lists. What we eat in America is the dietary intake component of HANES. The USDA conducts nationwide surveys of food consumption. The Behavioral Risk Factor Surveillance System conducts telephone interviews with adults 18 years and older. The Youth Risk Behavior Survey collects data on priority health risk behaviors of those in grades 9 through 12. Note, both the behavioral and the youth risk factor surveillance systems can monitor changes in health risk behaviors over time and can better target health promotion efforts to populations most at risk. The Health and Diet Survey randomly telephones adults. It tracks the prevalence of supplement use, relative nutrient intake levels, knowledge of fats and cholesterol, and awareness of diet and disease. For all of these programs, please note its acronym, who runs it, and what is involved. Referral procedures are essential for the continuity of care and to maximize services available from other sources. The following are nutrition assistance programs currently offered by the government. Know the acronym, who runs the program, who is eligible, and what services are offered. Under the Temporary Assistance for Needy Families program, states determine eligibility and the benefits and services provided. The USDA's Food Distribution Program provides foods to help meet the nutritional needs of children and adults. The Commodity Supplemental Food Program is run by state health agencies. The National School Lunch Program is an entitlement. Entitlements are assistance programs that require the payment of benefits to all eligible people as established by law. The lunch menu must provide 1/3 of the recommendations for the items listed. Team Nutrition helps schools meet the guidelines. The school breakfast program is also an entitlement program and requires that the breakfast meet the dietary guidelines and provide 1/4 of the recommendations for items listed. After-school snack programs provide healthy snacks. The Special Milk Program encourages the consumption of milk by children. The Summer Food Program is an entitlement program and aids food service programs for children when school is not in session. The Child and Adult Care Food Program provides healthy meals and snacks to child and adult daycare facilities. It provides food and education. The Fresh Fruit and Vegetable Program helps children develop eating habits that improve health. WIC is administered by the USDA and provides food for low-income mothers at nutritional risk. Risk includes medically based and dietary-based parameters. Food and nutrition education are provided. A health exam is required. WIC is not an entitlement program. FNEP is designed specifically for nutrition education. It is directed at low-income families. Home economists train nutrition aides to educate the public. FNEP works with small groups. They teach people how to budget, shop, and cook. The Maternal and Child Health Program is a federal program concerned exclusively with the health of mothers, infants, and children. The Healthy Start Program funds programs in communities with high infant mortality rates. The Elderly Nutrition Program falls under the Older Americans Act. Congregate meal services are for the ambulatory. Home-delivered meals are for the homebound. SNAP is the largest food assistance program, and it is an entitlement. It is an assistance program for low-income individuals and families providing monthly benefits. Medicare assists people 65 years of age or older and people of any age with end-stage renal disease. Part A covers hospital care. Part B is optional insurance for supplementary benefits. An annual wellness visit is provided by the Affordable Care Act to Medicare beneficiaries. Medicaid is a joint state and federal program providing assistance for all eligible needy. The Children's Health Insurance Program expands health care coverage to uninsured children. Head Start introduces new foods and teaches good food habits. The child's participation in food activities is an important part of the plan. The Nutrition Education and Training Program trains teachers and school food service personnel. The Senior Farmers Market Nutrition Program provides low-income seniors with coupons to be exchanged at farmers markets and roadside stands. Eligible foods include fresh, nutritious, unprepared fruits and vegetables, often locally grown. In addition to these government-sponsored programs, there are also quasi-governmental agencies that provide nutrition assistance. Examples are the Red Cross and the National Research Council. Non-governmental agencies that may have nutrition programs include voluntary agencies like the Heart Association, professional organizations like A&D, and foundations like the Rockefeller Foundation. The FAO is the international agency most directly concerned with food. Nutrition diagnosis is the second step of the nutrition care process. It identifies a nutritional problem, a risk of a problem, or the potential for developing a nutritional problem that dietetics professionals are responsible for treating independently. The nutrition diagnosis changes as the patient's response changes. The medical diagnosis is a disease or pathology that can be treated or prevented. It does not change as long as the condition exists. Know the difference between the nutrition and medical diagnosis. standardized terms are developed for each step of the process. Nutrition diagnoses are organized in 3 categories. The clinical domain represents nutritional findings or problems that relate to the patient's medical or physical condition. Functional balance refers to a physical or mechanical change that interferes with or prevents desired nutritional results. This would include a swallowing or chewing difficulty or altered GI function. Biochemical balance is a change in capacity to metabolize nutrients due to medications, surgery, or indicated by lab values as elevated lipid levels. Weight balance refers to chronic or changed weight status when compared with usual body weight. Underweight and involuntary weight loss are examples. The intake domain describes actual problems related to intake of calories, fluids, nutrients. The behavioral environmental domain refers to problems related to knowledge, access to food, and food safety. A nutrition diagnosis is best written as a PES statement pertaining to one problem, one etiology, and connecting signs and symptoms. The problem, the diagnostic label, is an adjective that describes the human response, such as altered, impaired, increased, risk of. The etiology is the cause or contributing risk factors linked to the problem by the words related to. Assessment of signs and symptoms are linked to the etiology by the words as evidenced by. Examples are listed. Select the most important and urgent problem to be addressed. Evaluate the PES statement by asking the following questions. Can you resolve or improve the nutrition diagnosis for this person or group? If you have diagnoses from 2 domains, consider intake diagnoses as more specific to the nutrition professional. Is the etiology you selected the root cause that can be addressed with nutrition intervention? Or can you at least lessen the signs and symptoms? Will measuring the signs and symptoms indicate if the problem is resolved or improved? Are the signs and symptoms specific enough that you can monitor and document resolution or improvement of the nutrition diagnosis? Overall, the question to ask is, does the nutrition assessment data support a particular nutrition diagnosis with a typical etiology and signs and symptoms? Please recognize the distinction between the following 2 diagnoses. Altered GI function looks at problems inside the GI tract, including exocrine functions of the liver and pancreas, with changes in digestion, absorption, and/or elimination. Impaired nutrient utilization refers to problems with the metabolism of nutrients once they have entered the circulatory system. This includes the endocrine functions of the pancreas, liver, pituitary, and parathyroid. Identifying the etiology leads to the selection of a nutrition intervention aimed at resolving the underlying cause of the nutrition problem when possible. If the intervention cannot be aimed at resolving the underlying cause, then the nutrition intervention is targeted at minimizing the symptoms of the nutrition problem. The critical thinking skills needed in nutrition diagnosis include finding patterns and relationships among the data and possible causes, making inferences, and prioritizing the relative importance of problems. If the assessment indicates that no nutrition problem currently exists that warrants a nutrition intervention, use the words "no nutrition diagnosis at this time." Nutrition planning and intervention is the third step in the nutrition care process. It is based on the nutrition diagnosis and provides the basis upon which outcomes are measured and evaluated. Sources for intervention methods include evidence-based dietetics practice. Our recommendations are based on scientific evidence. What does the best evidence tell us about the most effective intervention methods? The critical thinking skills needed for the intervention step are listed. Community-based intervention programs are divided into 3 categories. Primary prevention programs try to reduce exposure to a promoter of disease, such as early screening for risk factors like diabetes. This is health promotion. Secondary prevention programs recruit those with elevated risk factors into treatment. This is risk reduction. And tertiary prevention programs intervene as the disease progresses to reduce severity and manage complications. Consumers need guidance when evaluating new findings about food and nutrition. The FTC and the National Council Against Health Fraud monitor radio, television, and other advertising and investigate complaints. When evaluating information, ask questions based on the CARS checklist. Is it credible, accurate, reasonable, and supported by science? The care plan is entered into the medical record. How the recording is done is determined by each facility. Various documentation styles are listed. The medical record is a legal document. Information entries must follow the HIPAA guidelines. Note the discharge plan begins on day 1 of the patient's hospital stay. All patient information is confidential. The first group of medical conditions we will review are the gastrointestinal disorders, beginning with the ulcer. An ulcer is an eroded mucosal lesion. Note the cause of many ulcers is the H. pylori bacteria. Treatment includes antacids, antibiotics, rest, and diet therapy. Note the diet is as tolerated, whatever does not aggravate the patient's condition. Avoid late-night snacks. There are, however, some items known as gastric irritants which should be omitted from their intake. A hiatal hernia is a protrusion of a portion of the stomach above the diaphragm into the chest. Heartburn is the main symptom. Note the feedings should be small, and patients should avoid late-night snacks. Note the dumping syndrome occurs after a gastrectomy. After the patient recovers from surgery and begins to eat food in greater volume and variety, he may experience a cramped, full feeling, rapid pulse, perspiration, and dizziness. These post-gastrectomy symptoms are associated with the dumping syndrome. When a meal containing a high proportion of readily hydrolyzed carbohydrate rapidly enters the jejunum, water is drawn from the blood into the intestines to achieve osmotic balance. This causes a rapid decrease in the vascular fluid compartment, so blood pressure drops, and signs of cardiac insufficiency appear. About 2 hours later, this concentrated solution of carbohydrate is rapidly digested and absorbed, causing a rise in blood sugar. This stimulates an overproduction of insulin that leads to a drop in blood sugar below fasting. This is reactive or alimentary hypoglycemia. This series of events is the dumping syndrome. It occurs when the holding capacity of the stomach is decreased so food is literally dumped into the intestine. Billroth 1 and 2 are the surgical procedures involved in a gastrectomy. Billroth 1 connects what is left of the stomach to the duodenum. Billroth 2 connects it further down to the jejunum, so this is a more serious surgical procedure. When food bypasses the duodenum, the secretion of secretin and pancreozymin will be reduced. These are the hormones that stimulate the pancreas, so now there is little pancreatic secretion. That is what causes steatorrhea. The patient may develop a deficiency of iron, folate, or vitamin B12. Careful control of the diet can relieve these symptoms. Note the diet. Restrict simple sugars. Limit fluids during meals. Gastroparesis, delayed gastric emptying, is associated with surgery, diabetes, viral infections, and obstructions. Moderate to severe hyperglycemia may slow gastric emptying, with long-term detrimental effects on gastric nerves and motility. Prokinetics, like erythromycin and metoclopramide, increase contractility of the stomach and shorten gastric emptying time. The primary dietary factors that affect gastric emptying are listed. Provide smaller, more frequent meals. Shifting the diet to more pureed or liquefied foods is often helpful. Avoid high-fiber foods and fiber supplements. Fat in liquid form is well tolerated. Note the differences between the two types of sprues. Tropical sprue, caused by a bacteria, virus, or parasite, is a chronic recurrent GI disease characterized by intestinal lesions. Note the symptoms include deficiencies of folate and vitamin B12. Treatment includes antibiotics and a diet high in calories and protein with intramuscular B12 and oral folate supplements. Non-tropical sprue or celiac disease is a reaction to gliadin, a protein found in certain grains. This affects the intestinal tract, causing malabsorption and macrocytic anemia. To eliminate the symptoms, note a gliadin-free, gluten-restricted diet is imposed. Corn and rice are permitted. Constipation is treated with a high-fluid, high-fiber diet with exercise. In diverticulosis, small mucosal sacs protrude through the esophageal or intestinal wall. Note the diet is high in fiber. When these sacs become inflamed, diverticulitis occurs. Provide a clear liquid diet, gradually returning to the high-fiber plan. The major function of fiber in the diet is to provide indigestible bulk that promotes intestinal function. Note oat bran and soluble fibers decrease serum cholesterol by binding bile acids, causing more cholesterol to be converted into bile, which lowers the serum cholesterol level. Note examples of soluble fibers. Gastritis is an inflammation of the stomach. It is treated initially with clear liquids, advancing as tolerated. Inflammatory bowel disease has two classifications. Crohn's disease is an inflammatory condition primarily affecting the terminal ileum. There is diarrhea and weight loss. Note, because the terminal ileum is affected, a B12 deficiency may develop. Chronic ulcerative colitis is a disease of the colon. The colon's main function is to reabsorb water and electrolytes. Note, chronic bloody diarrhea and loss of electrolytes are major symptoms. Treatment for IBD begins with maintaining fluid and electrolyte balance and may include the use of an anti-diarrheal agent. Nutritional management includes energy needs according to current BMI, limit fat only if steatorrhea is present, frequent feedings, with vitamin-mineral supplementation. The nutritional goals in treating irritable bowel syndrome are to provide adequate intake, tailoring the pattern to their specific GI issues. The client should track their intake and associated symptoms, assist them in alleviating the stress associated with eating. Lactose intolerance is due to a lactase deficiency. Lactase splits lactose into glucose and galactose, which are easily absorbed into the bloodstream. If lactase is missing, the lactose molecule remains intact and exerts hyperosmolar pressure, causing water to be drawn into the intestines to dilute the load. This causes distension, cramping, and diarrhea. Bacteria then ferment the undigested lactose, releasing gas. The condition is detected with the breath hydrogen test or the lactose tolerance test. Note, if you are intolerant, after consuming lactose, the blood glucose level will rise less than 25 milligrams per deciliter above fasting, presenting a flat glucose curve. If you are tolerant of lactose, the rise would represent a normal glucose curve. Note, the diet excludes animal milk and milk products. Some do tolerate yogurt and small amounts of aged cheese. Acute diarrhea in infants and children is aggressively treated with immediate rehydration by replacing the fluids and electrolytes lost in the stool. Chronic, nonspecific infantile diarrhea is not associated with significant malabsorption. Look at the ratio between the nutrients provided and the volume of ingested fluids. Some infants are inadvertently given a diet that has too little fat, too many calories, or too many fluids. To control the condition, adjust the fat intake balanced with limited fluids. Note, restrict or dilute fruit juices with a high osmolar load, like apple and grape juice. Children up to age 6 should be limited to 4 ounces of fruit juice per day. Besides bowel rest, the nutritional care for the adult with diarrhea includes replacing fluids and electrolytes lost in the stool. Prebiotics and probiotics may help. Steatorrhea is a consequence of malabsorption. The short bowel syndrome results from significant resections of the small intestine. The severity of the condition depends upon the length and location of the resection and the health of the remaining tract. Particular concerns include the loss of the distal ileum, the loss of the ileocecal valve, and the loss of the colon. Most digestion takes place early in the intestine, in the duodenum and upper jejunum. If the jejunum has been resected, the ileum over time can take over its functions. It is when the ileum is resected that the patient experiences significant challenges. Note, the distal ileum is where bile salts, the intrinsic factor, and vitamin B12 are absorbed. The ileum also absorbs most of the fluid passing through the tract. If bile salts are not reabsorbed, the liver is not able to produce enough to adequately emulsify lipids. Fats and fat-soluble vitamins are malabsorbed. Initial care includes parenteral support. Enteral feeding should be started early and increase gradually over time as adaptation allows. Following a jejunal resection, provide a normal balance of nutrients. Note, but following an ileal resection, fat intake is limited. Without the ileum, bile salts are not recycled, so are not available to emulsify fat. Provide some fat as medium-chain triglycerides, which do not require bile salts. They also require less intestinal surface area for absorption. Parenteral B12, followed by monthly B12 injections, may be needed. The liver controls a major portion of the body's internal environment. When the liver is diseased and its usual activities do not proceed normally, many metabolic functions are disrupted. A healthy liver stores and releases blood, filters toxins, metabolizes nutrients, and regulates fluid balance. All of these are affected during liver disease. The enzyme profile is a list of the major enzymes found in the liver. When tissue damage causes them to leak out into the circulation, the enzyme level in the blood rises. Note, elevated enzyme levels indicate tissue damage. Under the heading Liver Function Tests are the 4 enzymes evaluated. Note, in liver disease, they are all elevated. Hepatitis is an infectious disease characterized by inflammation and partial necrosis of the liver. Necrosis is the death of a tissue due to lack of oxygen. Note, anorexia is a major symptom. Provide a high fluid intake to guard against dehydration. Nutrition care varies according to their symptoms and nutrition status. Include 50 to 55% of energy as carbohydrate to help replenish liver glycogen stores. Provide 1 to 1.2 grams of protein per kilogram for those with acute hepatitis. The high protein intake not only helps the liver regenerate its cells, but it also provides lipotropic agents to convert fat into lipoproteins to move them out of the liver. So the high protein intake helps prevent a fatty liver. Provide a moderate to liberal fat intake if tolerated. Limiting fat may be needed with steatorrhea. Note, the difficulty in providing this much nutritional support is that hepatitis patients are often anorexic, so small, frequent feedings are advised. Liver disease may advance to the chronic state of cirrhosis. Here, the liver attempts to regenerate its damaged cells by replacing them with bands of connective tissue. This tissue is non-functional and divides the liver into small irregular clumps, disrupting the flow of blood through the liver. Increasingly poor food intake leads to a number of nutritional deficiencies. Protein deficiencies may contribute to ascites, a fatty liver, or impaired blood clotting. When the liver is healthy, blood from the esophageal, abdominal, and collateral veins enters the portal vein, which takes it to the liver to be cleansed. Blood then is redistributed back through the body by way of the vena cava. Note, ascites occurs when blood cannot leave the liver. The problem is the connective tissue overgrowth. As it blocks blood flow out of the liver into the vena cava, the blood backs up inside the liver. The liver, acting like a sponge, can store about 1 liter of excess blood. But once that storage capacity has been exceeded, there is no place for the blood to go. It can't leave the liver, and it can't stay inside the liver. so fluid from the blood seeps through the liver into the peritoneal cavity. This fluid is almost pure plasma with a high osmolar load. That pulls in additional fluids from surrounding tissues. Note, this accumulation of fluid and the sodium that it carries is ascites. Another complication of cirrhosis is the development of esophageal varices, which develop when blood cannot enter the liver. The problem again is that connective tissue overgrowth. As it prevents blood from entering the liver through the portal vein, the blood backs up into the vein, causing, note, portal hypertension. This increased pressure forces the blood back upward in the system, increasing the blood pressure in the abdominal and esophageal veins. Increased blood pressure in these small, fragile vessels forces an outpouching of the vessel wall known as a varice. These varices are very fragile. They can burst open on their own or can be torn open with a diet high in roughage. Note, the nutritional therapy for cirrhosis includes a high protein, high calorie, moderate fat intake. Restrict fiber if varices are present. Restrict sodium as needed. Fat is the preferred fuel in cirrhosis. Include omega-3 fatty acids. Decrease LCTs if steatorrhea develops. Alcoholic liver disease has 3 stages: steatosis, fat buildup, hepatitis, and cirrhosis. It is due to the constant presence of alcohol itself and the metabolic changes it causes. Alcohol is converted to acetaldehyde, releasing large quantities of hydrogen. The hydrogen steps into the TCA cycle in place of fat, so the fat accumulates either in the liver, leading to a fatty liver, or in the blood, raising the triglyceride level. Malnutrition usually accompanies the disorder. The major nutritional concerns are listed. Note, a long-term thiamine deficiency may contribute to the Wernicke-Korsakoff syndrome. Hepatic failure or end-stage liver disease occurs when the function of the liver decreases to 25% or less of normal. Here, the liver can no longer convert ammonia into urea, so it builds up in the blood, leading to confusion, drowsiness, and coma. Note the diet. For the patient who is not comatose, provide moderate to high levels of protein. To minimize muscle catabolism, provide extra energy from carbohydrates and fats. In encephalopathy, the normal ratio between neurotransmitters is altered. The level of the branched-chain amino acids is decreased, and the level of the aromatic amino acids is increased. It is thought that this abnormal ratio brings on many of the symptoms associated with the condition. Note, one therapeutic approach is to attempt to correct this imbalance by giving the patient more branched chains and fewer aromatic amino acids. This also is a way of providing additional nitrogen to the patient. However, this seldom alleviates the symptoms. Cholecystitis is an inflammation of the gallbladder that usually results from a low-grade infection. Treatment includes a low-fat diet. Note, following a cholecystectomy, bile is directly secreted from the liver into the intestines. Pancreatitis is characterized by edema, cellular exudates, and fat necrosis. It may be the result of a blockage or reflux of the ductal system within the pancreas. A common characteristic is, note, the the premature activation of enzymes within the pancreas, leading to autodigestion. So the enzymes secreted within the pancreas digest the pancreas. In acute pancreatitis, withhold all oral feeding and maintain hydration. Then progress slowly with foods easy to digest and low in fat. Note, elemental enteral feedings into the jejunum may be tolerated. In treating chronic pancreatitis, note, provide oral pancreatic enzymes with meals and snacks to minimize fat malabsorption due to a lack of pancreatic lipase. MCTs do not require lipase and can be added to mixed dishes, jams, and jellies. Parenteral B12 and antacids may be needed. Provide fat-soluble vitamins in the water-soluble form. Because eating stimulates the pancreas, causing pain, avoid large meals with a lot of fat and alcohol. Cystic fibrosis is a disease of the exocrine glands, especially those secreting mucus. Chronic pulmonary disease, pancreatic enzyme deficiencies, and malabsorption result. Current therapy includes oral pancreatic enzymes with meals and snacks, along with a high-protein, high-calorie, unrestricted fat intake liberal in salt. Provide age-appropriate doses of the water-soluble vitamins and minerals. Supplement the fat-soluble vitamins, especially A and E. This domain continues on the next CD.